Hi, this is Lisa Costa-Bir. Join us on FX Medicine next week, where I'll be talking to women's health physio and naturopath Lisa Tate on all things pelvic floor and more. Subscribe to us on your favourite podcast app and follow us on social media to make sure you never miss an episode. Hi, I'm Lisa Costa-Bir and welcome to FX Medicine, where we bring you the latest in evidence-based, integrative, functional and complementary medicine. FX Medicine acknowledges the traditional custodians of country throughout Australia where we live and work and their connections to land, sea and community. We pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. With us today is Naturopath Sandra Villela. Sandra has been in practice for almost 3 decades and runs a busy practice in Melbourne. Sandra has a particular interest in women's health and is also a consultant naturopath and clinical leader for Jean Hales, Australia's leading women's health organisation, a position she has held since 1999. Welcome to FX Medicine, Sandra. Thank you so much for being here today.
Thank you, Lisa. It's a real pleasure to be able to talk about something that I feel quite strongly about, and I know you and I have spoken about. There's a bit of misinformation around this topic, so I'm really pleased to be sitting here and nutting it out with you.
Oh, me too. And I've been counting down the days for us to have this chat and really bring awareness to what premenstrual dysphoric disorder is all about. And I'm going to call it PMDD from now on because it is a bit of a mouthful. So if we look at the stats, PMDD is incredibly prevalent. 3 to 8% of women worldwide have it, including me. So I'm very excited to chat about it. But it's also very under-recognised. And because it's under-recognised, I feel like a lot of women go undiagnosed or they're misdiagnosed with bipolar or PMS. So maybe you could start by telling us what PMDD actually is and differentiating between PMS and PMDD because they get lumped together a lot, even in the research. Yes. So tell us how they're different, I guess.
I guess I have a bit of a biased approach because I actually see so many women with PMDD and I get lots of referrals, particularly from the GPs at my work at Jean Hales. And also the stats that you were talking about in terms of the percentage, if you look at what happens to women, you know, you think about that 3 to 8% of women, roughly what it works out to be is 1 week per cycle they would experience about 8.6 years, cumulative years of symptoms.
Oh my gosh.
And so that's really similar to what someone with recurrent major depressive disorder would experience across their lifetime. So it really does have quite an impact. And I see a little bit of a merging distinction between PMS and PMDD. But as most people would know, the PMDD does have a DSM-5 criterion, so it's like it has a psychological criteria. And there's 4 categories.
That's right.
And particularly women need to have at least 4 of the section of number A, which is kind of looking at a lot of the anxiety symptoms, you know, marked depressed moods, marked anxiety, affective lability, persistent and marked anger. I'll just list these and you can decide to keep them or not. Decreased interest in usual activities, and I think that's a key one. So work, school, friends and hobbies. And a subjective sense of difficulty in concentrating, lethargy, easy fatigability or marked lack of energy, marked change in appetite, overeating or specific food cravings, hypersomnia or insomnia, and a subjective sense of being overwhelmed or out of control. Other physical symptoms, you know, such as the breast tenderness, swelling, headaches, joints or muscle pain and a sensation of bloating or weight gain. So they need to have at least 5 of those 11 symptoms, and then there's criterion B and C. But I think the distinction is if the person feels like it significantly interferes with their ability to be social in terms of occupational and their interactions, their sexual interactions, their scholastic functioning. I think that's the big distinction.
Yeah. I've had a partner say to me previously, it's like a Jekyll and Hyde change. You're totally nice and normal and then you turn into this other person, and I've never seen anyone kind of flip so quickly. I've had patients say to me, like I've had a patient that constantly lost her job because she just morphed into this other person after ovulation and was really difficult to deal with. So you're completely right. It's that really marked change.
And I think the thing to acknowledge about that is these people feel out of control.
Yes,
it
definitely.
Really is. They can't do anything about it. It is really like something takes over. And when we'll talk about the understanding of it, we'll get an understanding of why. And so, yes, it is disruptive.
Yeah, a lot of people feel like it's very overwhelming. It's like there's a flip that gets switched. Okay, so you mentioned that it fits into that DSM-5 criteria, and I know that in 2022 it was also classified as a gynaecological disease. So we're seeing this kind of marrying between female repro and depressive disorders. How do we view this naturopathically?
Well, I don't think we've done this very well in the past. And I think that's what I'd really like to highlight in this discussion, is that previously I think traditionally and like for 30 years, we've kind of looked at this PMS as being an estrogen dominance condition.
Yes.
And that is my real bugbear. I absolutely hate it, and I've done talks on trying to debunk the myths.
Yeah.
But it is this marrying, and what we know about the etiology of PMDD, it's an interaction between the steroidal, these gonadal hormones and our neurotransmitters.
Yeah.
So if it's in both, and then look, in Melbourne we have a whole unit at the Alfred where it's dedicated to mood and hormones, and it's so while it is a gynecological, it really is a mental health disorder as well.
Yeah. I guess that's the real beauty, right, and of what naturopathy does. I think sometimes we like to compartmentalise conditions into systems, but it's a really beautiful depiction of the synergy between systems and how one system always affects another.
The beauty is, as naturopaths, we have fantastic tools to be able to deal with this. But one of the things that I'm really keen to do, and like my understanding changed after the new guidelines came out in 2017. And these 2017, there was these guidelines that came out from the Royal College of Obstetricians and Gynaecologists. It's a great big fat paper, but it talks about the new theories. And so I presented at the NHAA International Conference, I think in 2019 or 20. And this has opened up a really good discussion. A lot of my colleagues who I really respected to do a lot of work with reproductive health and with women's health, we had great conversations about this. I know that I was hoping to change the way we think about this. I'm not saying I'm the one who did it, but it's certainly, I know my colleagues in Melbourne kind of thought, okay, we need to look at this differently.
Yeah.
And we do have these great tools, but it's how we look at it. So I think rather than looking at the hormones, because all the research is showing there are normal levels of hormones, all of the hormones. So estrogen, progesterone, the metabolite of progesterone, which is really interesting, allopregnanolone, which I'm sure we'll talk about.
Definitely.
All normal levels, whether you've got PMS, PMDD, or you're asymptomatic. It's the altered response and the suboptimal response at the level of the neurotransmitters, particularly GABA with the allopregnanolone and progesterone, and the relationship between estrogen and serotonin. And so I think that's the key thing. And so what we want to do is we target those. We can do stuff with all of those. We can modulate these neurotransmitters. And one of the things I'd love to, I don't know whether anyone's looked at this, but I wonder whether some of the ways our beautiful medicines work is it's working on the plasticity of those receptors to respond better.
Yes.
Because when research has been done to look at altering the metabolism of these hormones, it doesn't make a difference.
Yeah.
So it's really looking at the level of we've got great medicines to work at the level of these neurotransmitters.
Definitely. So let's chat more about what you've said, because from what I've understood is that it's not an excess of estrogen. We don't need to clear excess estrogen out. Estrogen isn't the bad guy. Progesterone isn't necessarily the good guy that we want to increase, because that can cause problems too. It's more that these women have a sensitivity to normal fluctuations that are occurring between the hormones, and there's a flow-on action to the neurotransmitters in the brain particularly.
And I actually find that's really difficult. Sometimes it's with my students,
Mm.
it's a really difficult concept to understand. And I think the whole idea about estrogen excess, as you know, I hate, I use different terminology like estrogen dependent. This is not an estrogen dependent or excessive condition.
Absolutely.
And so there are times when estrogen clearance is highly appropriate if you're dealing with an estrogen dependent condition like endometriosis or gynecological cancers. But here, particularly, if we do that, it can worsen symptoms.
Definitely.
And if I give an example, particularly of a perimenopausal woman
Yeah.
who already has a bit more sensitivity to the decline in the estrogen. Now, I am talking about a decline in estrogen, that normal endogenous decline in that premenstrual phase, where some of these women in their 40s will get PMS, if we can just deter from this classic PMDD, because I really wanted to introduce this perimenopausal PMS. They get these night sweats, low mood, hot flushes, headaches in that phase. You go in and do estrogen clearance, you're worsening their clinical outcome.
Exactly. Yeah. Pet peeve of mine too. So these hormones, in terms of how they work in the brain, they're actually called neuroactive steroids, right?
Yes,
I think a lot of the time when we're at uni and a lot of the general public just think that the hormones are there to kind of give us a period and that's all they do. But they're actually made in the brain from cholesterol, right? And that's in part how they work in terms of their behaviour and mood effects and what we see in PMDD. There's receptors, right, for hormones.
I love that you brought that up. There's these neuroactive steroids, or NAS, we can call them. And they are, they're produced in endocrine tissue or brain, and they interact with these neuron receptors like GABA. And look, I don't claim to know the specifics of the different receptors, but it goes into the specifics of which GABA receptors. And then these neuroactive steroids are like pregnenolone, progesterone, oestradiol, and also corticosteroid. And the interesting thing is progesterone and allopregnanolone, which is a metabolite, normally they actually work to make you relax. They modulate GABA. But somehow they have this paradoxical effect in women with PMDD, or sometimes they talk about whether it's the drop that might be triggering. So the problem is we don't know. So if you come in and try and increase the progesterone metabolism or increase progesterone levels generally, and this woman is sensitive, then again, we could get the wrong outcome.
Yeah, that's actually happened to me. I was actually prescribed pregnenolone and I literally cannot describe how bad it was. It was like a manic psychotic episode.
Absolutely.
So I think it's really important to bring that up.
Yeah, and there's 2 points that I'd like to make about that, like in terms of how we treat allopathically, but also if we look at the current theories of what this is, it still says, if you look at PMS and PMDD, there is uncertainty around the etiology, but it revolves around the ovarian hormone cycle. And the two theories are that some women are sensitive to progesterone and the progestins. Now, again, if you're sensitive to these progestins and in endogenous progesterone, you get put on the pill, you're going to be sensitive to those progestins. The newer generation progestins in the pill you might be better at, and possibly progesterone, like in terms of the progesterone now that's prescribed as a body identical, not bioidentical, but body identical, you may get response, but it will often worsen them. If you're already sensitive, you're going to be sensitive to these exogenous as well. And then the other one we talked about where there's this interaction or responsiveness of the neurotransmitters, serotonin and GABA. They're responsive to estrogen or the progesterone or the allopregnanolone respectively. So these neuroactive steroid hormones are really working, and changing the metabolism of those hormones isn't the way to go, but maybe working at how we can target the neurotransmitters particularly and the receptors.
Yeah. So you've mentioned allopregnanolone, and I think, again, we hear a lot about progesterone, we hear a lot about estrogen, but we never hear about allopregnanolone. And I came across it a couple, maybe 4 or 5 years ago, not a couple, and it was reading an Instagram post on allopregnanolone that actually alerted to me to the fact that, okay, I think this is actually what's going on with me, and this is why the standard B6 and magnesium just is doing nothing. So can you tell us about allopregnanolone?
Yeah, look, the more I read about it, the more I find it intriguing. So it's synthesised from progesterone. There's a couple of steps that do it. And there's some theory about women might be having a higher expression of one of the enzymes but there's no direct evidence to date that women with PMD have any alteration in that enzymatic pathway from progesterone to allopregnanolone. So traditionally we might have wanted to improve progesterone, and certainly you want to think, oh, should we improve that pathway? But there's no evidence that it does. And so what the research looks at, it's not likely the absolute level of this allopregnanolone, but certainly it's very important, but changes in its levels across the luteal phase that trigger PMDD.
Yeah, that's right. And so when the woman is sensitive, as you said, she's getting those symptoms of aggression and anxiety or depression. But I think something important to note is this is only happening in the luteal phase, right?
Yes, yes. And I think that's the distinction. When we talk about premenstrual syndrome and PMDD, it can be a lot of symptoms, but it's when it occurs. It's not how much or the level of it or the degree of it. It's the fact that it has to be in that luteal phase and should resolve within the first few days of the cycle. If you've got, and we need to make that distinction, because sometimes women are getting an exacerbation of an underlying condition.
Yes.
So if you've got anxiety all the time, you might get an exacerbation of this. But it's interesting, one of the things that I'm really interested in, I don't think we have the answer to, it seems to be this plasticity of these GABA receptors or their subunits in response to these neuroactive steroids, a fluctuation. That may be the key aspect of PMD pathophysiology. And I don't think at this time we've got limited animal research. And I wonder, and there will be people out there smarter than me that might say that actually some of the nutrients we're using are actually working on that plasticity of the receptors.
Yeah,
and I think that's still to come.
Oh, I'm dying to talk more about that, but I'm just going to store that away for one sec and then come back to it.
I can't expand on that anymore. It's a theory, and I think there might be, in 10 years' time we might know more about it.
So we've talked about allopregnanolone, and really it is the main kind of metabolite that is involved with PMDD, but so is serotonin, right?
Yes.
We know that women are often prescribed SSRIs for management of PMDD, and they're one of the first-line treatments. But what's going on with serotonin in PMDD?
Well, that's interesting. So the serotonin-estrogen relationship is more distinct.
Yeah.
And I was just reading before, trying to get my understanding around how the SSRIs work. And some work better than others, and certainly in the guidelines they give specifics in terms of, and when we talk about the allopathic interventions, I think then they talk about how maybe they then have an impact on GABA, because the serotonin we always think about as the happy hormone, and I kind of focus on that one a lot more and target that serotonin sparing, particularly with the low mood that will occur. And you do get a normal endogenous drop of estrogen just beforehand, and that's often, the low mood is just prior often to that period. Do you notice that? You get all that agitation and irritability and then that low mood.
But I see it, like a lot of my patients say to me, it's like literally they feel amazing at ovulation, and it's literally straight after that drop in estrogen that they notice, now it started, then it kind of levels out, and then again at that second drop in that mid-luteal, things really kind of, they run into problems.
And again, we don't want our practitioners to work on the estrogen levels there, although, but again, it's how it then has this conversation with serotonin. Professor Jo Shura-Kulkarni, who heads up MAPS at the Alfred, she's got great stuff about how estrogen works on serotonin. And I think also we as naturopaths, traditionally we demonise estrogen. Estrogen rocks,
love it.
So that does have an impact on our brain. I'm really interested in some of the serotonin sparing herbs for PMS, and my key one, and I know you like this one too, is if we can bring it in, is saffron.
I love it.
And I do tend to use that more than I do with St John's wort, and because often a lot of the people I'm seeing are already on an SSRI, and so saffron you can use, but you can't use St John's wort, and so the SSRI gives them some relief, but not complete relief.
Yeah, I think it's something like 40% of women don't respond to SSRIs. I mean, and that's a huge percentage that do, obviously, but sometimes there's a whole lot more we can do. Yeah, I love saffron. So it sounds like you do that throughout the cycle.
Yeah, I do. Look, it's interesting. when you look at the allopathic treatment, they sometimes just use cyclical SSRIs, and then if that doesn't improve, then they'll increase the dose or they'll use it throughout the whole cycle.
Yeah.
But I tend to use saffron throughout the cycle. But given that the SSRIs might work, that they just work in that luteal phase, and I don't know the pharmacokinetics of how quickly the saffron works.
I found that literally I could just do it in one shot and I will notice a difference straight away. Yeah, so I think it's working pretty quickly.
Yes.
But I mean, I'm like you, when I'm doing the liquids, my patients get it throughout the month.
Yes. Sometimes I will alter the dose. Like if we look at the guidelines, it's one of the things about the guidelines that I talk about, and I'll put a reference in, is they had about 2 or 3 pages, now this is back 2017, of the research of complementary medicines and therapies. So it actually gave a literature review, and some of them were kind of a bit novel. But in the guidelines, in that first line of intervention, B6, is talked about as first line. So it says exercise, cognitive behavioural therapy, B6. And then, interestingly, arguably there's insufficient evidence about what B6 does, but we know as practitioners, how might it work? You know, it has a role to play in the synthesis of GABA and serotonin. It tends to be a precursor for those. And we have to be careful with the doses.
What sort of dose do you tend to do?
Yeah, really interesting. So I look at levels between a baseline 50 to 100 and never any more than 200 because there are cases of peripheral neuropathy, and I might increase it in that luteal phase, but no more than 200. What sort of doses are you using with the B6?
Well, I don't use B6. I feel like I only use calcium is my number one. And
I love to talk about that.
Yeah, I feel like my patients have already tried magnesium, and it's not to say it hasn't helped, but it just hasn't been enough. So I use calcium, magnesium, D. And I feel like calcium is the VIP when it comes to PMDD. Like it just works so well.
And interestingly, naturopaths love magnesium. There's limited scientific evidence of magnesium working. Clinically, I feel like it works. But in fact, arguably one of the best levels of evidence we have for the management of PMS and PMD is calcium.
Yeah.
So originally in 2009 when they came out, it's really high doses, 500 milligrams BD of calcium carbonate. So we're not going to use calcium carbonate. We'll use better forms. And then later on there was a study looking at 500 milligrams daily, reduced PMS. And one of the things particularly, it was the depression that was useful. And so I think a lot of naturopaths forget about calcium. Yeah. And so I do use the both together.
Yeah, I found some really interesting research with calcium, and you might already know this, but I was shocked. Calcium follows a similar pattern to estrogen in the body. So women with PMDD show these alterations in cyclical calcium homeostasis, and it's because they're so sensitive. Well, we know estrogen kind of modulates calcium anyway in the body, and so when estrogen withdraws, we see a drop in calcium as well. So calcium is responsible for essentially neurotransmission and release of monoamines like serotonin and dopamine. So when we have this dysregulation of calcium in the luteal phase, basically those calcium channel gates don't open properly, and we see this neuronal dysfunction and this probably, I don't know if it's no release, but impaired release of serotonin and dopamine.
Wow, that's fantastic.
Yeah, which drives a lot of this mood stuff.
Really hard to find evidence. Obviously you have on the calcium, and I think I searched and I will often say, look, I don't know why it works, and I think I found some reference to how it might have been working with schizophrenia, like this one line. But yes, I think it's underutilised in this area and probably has one of the best levels of evidence.
Yeah, and then if you look at the signs of low calcium, the mood deficiency symptoms, it's actually mania, irritability, hostility, aggression, which is very similar to the PMDD. So I think probably like a lot of women in their menstrual cycle, I feel really good in that follicular phase and I don't take
Yeah.
any of my supplements, and then
Yes.
I go, I'm starting to, that person
Yes.
chewing next to me is really irritating me. I can hear that person breathing and I'm filled with rage. And as soon as I take the calcium, everything feels calmer. Those feelings are still there, but instead of them being an 11 out of 10, they might be like a 3 or 4 out of 10. They're not as overwhelming
great.
and unmanageable.
I really appreciate you sharing your experience too, and I think the listeners will benefit from it, having as from a practitioner point of view and from a patient point of view. But look, and also, how many of your patients do you feel like are getting adequate calcium in their diet?
Oh, I mean, hardly any. Yeah, this is the thing. Yeah.
Particularly with, sort of any dairy exclusion. I know dairy's not the only answer, or certainly with diets that have got exclusions, it's quite difficult to achieve.
So do you have any other favourite supplements?
Yeah, so I'd love to talk about Vitex.
I actually said to you, would you like to talk about Vitex?
I know. Do you know, I'm one of these practitioners. So many students and practitioners are scared of Vitex.
Yes.
I'm not. And first of all, I really don't think we know how it works.
Yeah, I was going to say,
how does it work? That it works.
Okay.
Standardised extracts of Vitex agonist casters do work. And I think as naturopaths, we think that has something to do with the hypothalamic pituitary ovarian axis, but it is also working on estrogen receptors. It probably has a direct action on estrogen. I think the thing that I'd like to tap into a bit more, and I don't claim to understand, is because it works on dopamine. Yeah. Somehow that may be how it's working for the mood aspects.
Interesting. Because I feel like there's a real art to prescribing Vitex, and tell us more.
I think I'm just gung-ho with it. Like, I just think sometimes, what happens is sometimes I'm not using it and do all the neurotransmitter stuff and use the nervines and the B6 and magnesium, calcium, and I think, do you know what? I really need to use some Vitex with this patient, and it works.
Have you ever had a patient where it makes, I guess where I'm worried is I've taken it and I just felt terrible, worse mood. So now I'm always cautious. I'm scared. But have you ever had a patient where you've given it and you've gone, or they've come back and said, I felt terrible?
Usually no. And I've got really trusted colleagues who've got all these rules about using it and don't use it without testing. I'm not a big tester. I don't do lots of testing. I don't feel like you need to have any, and certainly because we know that the hormone levels aren't relevant with this anyway. I usually warn people, I'll say to patients, we need to do this for 3 months.
Yeah.
And I always say, for some reason, the first period is often more painful if they do have dysmenorrhea. Don't know why. And sometimes in that first month, there's a worsening of cyclical nostalgia. And I just say, hang in there. And there's a small handful of people who will get headaches, and I usually ask them to persist because it usually goes away. And there's probably a minority of people that I won't continue Vitex with. So it's funny. I've got this thing, to Vitex or not to Vitex, and I reckon, and there's very few times that I wouldn't use Vitex, but it's not always my go-to. But I've used it for years, 30 years, and I still don't think we know how it works. Yeah,
that's right. I love that you were talking about that it may work on estrogen receptors, because I've never heard that, and we always just hear that we know that it helps to decrease prolactin. We know that it can increase LH, but a lot of people kind of say it's progesterogenic, and I think that's because of what it does with prolactin, but I've never heard about that estrogen aspect before.
And I kind of ignore that a little bit, because we always think that what does it do is, I think what it will do is it will facilitate or help with ovulation, and we know that with our fertility patients it has an impact on doing that. And so it's also good for the perimenopausal, premenstrual woman who might have irregular cycles. But I think the other thing is there's some really dumb things out there about how people use it only in the cyclical phase. Traditionally, every day, if you're starting it in the luteal phase, you've missed it, because it's got to work on that ovarian follicle development, if it's called that follicular phase. But I think it has a use. It's not always the way to go. And, of course, you can't use it if someone's already on the oral contraceptive pill.
Okay, so if you were going to give Vitex, you would give it all month. And do you suggest starting it on day 1 of the cycle?
Always, as close to day 1. If you've got someone who's a bit oligomenorrhaeic, just kind of risk it and say, look, it might mean that your period comes earlier or later. But yes, I do, day one. And the other thing is I think particularly young practitioners or, early out, they'll think that they only need to take it for 3 to 6 months and that's it. A lot of people just need to be on it for a long time, years.
Wow. Okay.
So I'm not scared of doing that. Usually the first 17 years of my practice, I worked with Ruth Tricky, and she used to say, generally there's a little sign if you've been on it for too long, the cycle starts to get longer. It stretches out and then you can have a little break. I've got another colleague who stops it for a few months and then starts back on. Unless there's reason to stop it, I just keep going.
Yeah, and to be honest, I think with conditions like this, I don't know if PMDD ever completely goes away. Do you know what I mean? Until you're maybe like menopausal. So it's more
That's
about
a really
just
good point.
Continuous use to really minimise symptoms and make everything more bearable. But it's very unusual for me, in my experience, for it to completely go away.
That's right.
Yeah.
It's a management strategy, an ongoing management strategy.
Yeah.
And really, unless you have a oophorectomy or until menopause, and then of course you might, women with PMDD are more likely, unfortunately, to have low mood at menopause. Yes. But we don't know. There's no way of predicting.
Can we go to what you were just talking about before about the partial hysterectomy? Because I'm on a Facebook group for women with PMDD, and because I feel like generally my symptoms are quite well managed, like now definitely with what we do naturopathically, I am always very shocked to see some of the posts that are being written, and you've got young women that are really struggling, and I'll talk about that in a sec, but there are some women that are opting to have a partial hysterectomy because their mood symptoms are so bad.
Yeah.
So can you run us through some of the allopathic?
I can.
Yeah.
Look, it's in the guidelines. It's the fourth line of intervention where you've got this surgical treatment. So it's an oophorectomy, a bilateral oophorectomy. I think a uterus is usually left because that's where it's coming from, the ovaries. It's not the uterus. And I've had one patient who had that done last year and on medication, and, she was knocking at the door of menopause and was kind of like, can you hang in there? And it was, she opted for that, and it has made a difference. But of course now she's got menopausal symptoms, but they are far more manageable.
Yeah.
So it does. It's concerning that on that Facebook page there are young sufferers of PMD opting for that, because there is so many things that can be done before that.
Yeah. I find all the things naturopaths and holistic nutritionists recommend extremely helpful. But I do know in some other countries they do offer allopregnanolone blockers, which I find really interesting because the research suggests that reduces mood symptoms by sometimes up to 75%.
So they're blocking the allopregnanolone directly.
Yeah, they don't offer that here, but any of those meds here, but I kind of thought that was really interesting. Yeah.
Look, the third line of treatment, they use the GnRH analogue, so they basically put you into a biochemical menopause, and then they do a bit of add-back hormone therapy, so they'll use like oestradiol and progesterone. So they'll use like an oestradiol patch, so body identical estradiol, and then they'll use, or a gel, and then they'll use the micronized progesterone. But again, look, if you're sensitive to these hormonal changes, you're going to be sensitive to the exogenous as well.
Yeah.
But, to those people, I would say at least before you have a surgery, try what it's like at a biochemical level, like at least go on the Zoladex or whatever it is to see if you're starved of those hormones.
Yeah.
It's pretty extreme.
Yeah, it is. I want to just run back on something you were talking about before, and that is your patient that had some pretty severe depression, it would seem. And definitely when a lot of my clients come to see me, the main kind of driver for them coming is that they're experiencing these extremes in mood, and they've sometimes got small children and partners, and there's this real shame and self-loathing that comes with their behaviour and the way that they behave towards their loved ones, but also just this very strong depression. And we know from the research the menstrual cycle has been found to be a trigger, increasing risk of suicide in women who are more hormone sensitive. Meta-analysis shows this. And in the last, I think, couple of years, there's been at least 3 meta-analyses that show that women with PMDD should be considered a high-risk group for suicidality. In fact, I think in one survey, it was like 30% of women had reported attempts to end their own life. So do you think then as practitioners we should be doing our DAS and working in line with a psychologist, or is that something I mean, I know you do, but...
So, look, I'm quite privileged. Most of the patients I'm seeing are co-managed by a GP. Usually at Gene Health, we share patients, so we can actually share the files. Certainly, most people will definitely be encouraging to see a psychologist, the cognitive behavioural therapy, and I know you want to talk a bit about trauma or whether it's trauma-based therapy.
Yeah.
And I think the idea of some sort of prom, so we can look at what's happening, even with, the old menstrual cycle, or using an app that looks at what's happening. And the idea of the DAS, yes, I guess to differentiate between is this cyclical or is it generalised anxiety disorder? Is this person a depression risk?
Yeah. I often find the patient's been seeing a psychologist and it's the psychologist that's actually picked up, hey,
absolutely.
This is a cyclical thing. Let's see, referral to the naturopath for some assistance there. But some patients, they've heard a podcast or something like that and they're not under the care of a psychologist. And I just find that working together with one, we just get so much better results,
Look, you raise a point about listening to a podcast, and unfortunately there is a lot of misinformation and nothing. I have a real bugbear with when patients come in and they're taking hormone balancing formulations that they've got from the internet, and it's kind of a one size fits all, put everything all in together, and some things might be okay, but you can't hormone balance. It's not about that. And so I had a patient who had gone on, because I think it's an estrogen excess, and gone on those formulas that really deplete estrogen, and just had really bad symptoms.
Yeah.
So, I think we're privileged to work with these patients.
Yeah.
And you've really, again, like we're naturopaths, it's individualised care.
Yes.
And I think it also brings in the other thing that we think about naturopathically. We've talked a lot about this hypothalamic pituitary ovarian axis, but the HPA axis, we do know that certainly if these GABA receptors fail to respond appropriately to these fluctuating allopregnanolone, you've got over the cross the menstrual cycle, it follows that these GABA receptors exert poor control over the HPA axis in PMDD as well.
That's right.
So there's this overlap. So it might be that the poor GABA regulation of the HPA axis may be reflected in this increased stress sensitivity of women with PMDD. So in that luteal phase, so of course, we've got to look at everything else. What's happening in their life? Are they having a poor diet? Are they really stressed? So it's not just working on those. Of course, we're going to be using our adaptogens. And
my favourite. Yeah. So going back to, I feel like the adaptogens are really king here and they really make a difference. And as you've said, women with PMDD experience this heightened stress reactivity in the week or two before their period. Things that wouldn't normally stress them out, they have this amplified reaction to it. And I think that's to do with the allopregnanolone, because normally apparently it helps with stress modulation, but it's not doing what it's supposed to. So it's not making us feel sedate and relaxed. It's doing the opposite. So coming back to that trauma, I find really, really interesting with a lot of my patients is that there is a trauma history. And I know trauma is kind of a buzzword at the moment and it's overused and misused a lot, but the research does show that women with PMDD often, not always, but there is often a history of trauma, and more so than women without. And I think that's an important consideration for practitioners to remember to be asking, have you experienced any big stresses in life? And again, it's coming back to that HPT, HPO, HPA axis. Yeah.
And Lisa, I love that you used the word, have you experienced any big stresses? Because even talking about trauma, we have to have that trauma-informed way of speaking. And I think the other thing is that we need to be respectful of is not necessarily asking the patient to recount the trauma. I have long-standing patients who might have had post-traumatic stress disorder way back before it was more common. And to this day, I don't know what the cause of that was because I don't need to know. I just need to know how it impacts the patient, and then I can do something about it.
Exactly.
She doesn't have to rehash that trauma. She can do that in a safe place. And that might be with you, or it might be with another practitioner, or it might be with her psychologist. But it's really important that, yes, we ask if there's been big stresses and how it impacts them. And that will help the way I think we shape our treatment.
Absolutely, because I think sometimes practitioners feel like, oh, I don't know how to deal with that if they do say something. And it is about staying within our scope, but also completely being aware that these things do impact the client's presenting complaint. Okay, so what about diet? Do you do anything special there?
Yeah, look, first line of the naturopathic therapeutic order, institute a more healthful regime, remove the obstacles to cure. There's a lot of people not eating well. Look, in terms of research, one of the things that's clear is alcohol. Any more than one standard drink a day is considered an increased risk. Interestingly, coffee, even up to, I think, 3 or 4 cups of coffee a day, has not been shown to have any impact. But I don't throw out.
I love it.
I know, but I sort of still think, from a naturopathic point of view, what's it doing to their nervous system? And look, I think in moderation, I do like coffee, and I'm not an anti-coffee, but I think if they're having 3 coffees, 4 coffees a day and not eating well. But
definitely.
Look, in terms of diet, I kind of look at it, and I'd be interested in your comments about making sure they've got the right macronutrients, particularly protein and adequate amounts of carbohydrate, good carbohydrates. And the carbohydrate picture is, interestingly, there was a big nurses study done on quite a lot of women that didn't seem to have any impact on carbohydrates, but low carbs, high carbs, I think you certainly want to be getting rid of the refined carbohydrates. But yes, often there's room for movement with diet, absolutely.
I often find women are skimping a little bit on the carbohydrates, and whole food carbohydrates are something I really recommend to my patients in the luteal phase, because I find that often because they're getting these wild cravings, and I think that's in part due to that withdrawal of serotonin, which can help to kind of govern satiety. When they feel like they're getting the cravings, like I can't eat, and so they deprive and then they binge. I think if, they just focus on just eating normally, which I know is hard sometimes, then everything is going to be a lot better. I also feel like something I recommend a lot is just prepping a lot more in the follicular phase, so that you have food ready for that luteal phase. Absolutely. When you know you're just not going to be motivated, the energy is going to be lower. So then if you've got the food in the freezer or the fridge, you're less likely to be calling for the Uber Eats and the DoorDash.
And that's in line with, first line of intervention should be planning. So, planning that sort of thing, and also planning like, you're not going to host family Christmas for 50 people if it happens to be in your premenstrual phase. No, give it to the sister-in-law this year. It's kind of like planning is really important. And I think some people are in really high-powered jobs, and I always say, if you're the CEO of this company, don't have your board meetings scheduled at that time. The planning is really important.
Yeah,
but it's interesting about the carbohydrates premenstrually that you said, like if you usually have a canned fish and salad at lunchtime, throw in some brown red rice or some sweet potato or some good healthy carbohydrates. So then you're not raiding the biscuit barrel
absolutely.
2 hours later.
Okay, last question for you. What about light therapy?
Yes, I haven't heard about that one, Lisa.
Okay, I'm really big on, is one of my favourite recommendations for everyone, but especially for women with PMDD. So there's been a couple of very small studies where they expose women to light, and essentially this could be natural light. There would be nothing wrong with, I usually say, go to the beach or just go outside on your veranda and get some natural light. It's better early in the morning, but when light hits our eye, it actually transmits to the brain and we get a release of serotonin. So what they've done in these clinical trials is they've given women a light that emits a specific frequency of the light. And so they're exposed to the bright light, and this actually increases their serotonin. And they've only done this in the luteal phase in women with PMDD, but they experienced an improvement in their mood. So we know generally light therapy helps with just regular old depression and seasonal depression. So they found that the same thing is great for women with PMDD. So natural light therapy is something I recommend to all my patients because, it's good for everyone, but especially good for anyone with a mood disorder.
Absolutely. And I like that. Sometimes I feel like I'm quite, when we talk so technically and whatnot about all of these, it's really important to think about naturopathic principles where, basically get into nature is, level 2. And in terms of stimulating that healing process, and how do we do that? Get into nature. And I love that there's more of this awareness of this kind of green psychology. And so That's an interesting point. I wonder then, Lisa, if it seems to be a worsening of the PMDD in winter
Yeah,
compared to...
I think so. I do know that plasma melatonin has been shown to be delayed in the luteal phase of women with PMDD. So if we think about that serotonin-melatonin kind of relationship, and it's probably something to do with that too. But I definitely find, I can speak for myself here, definitely worse mood and motivation in winter than in summer. Yeah.
Interesting.
Yeah.
I know. That's a good one.
Well, thank you so much. I've learned so much, and I'm sure our listeners have just gotten so many gems from you. Key points today that I've taken away are probably, the big one is good old Vitex. I'm going to give it a second chance.
Don't be scared, yeah.
I'm going to see how I go and report back to you. Vitex for management of PMDD symptoms, giving it first thing in the morning and all through the cycle. Second one I really have to highlight is both our favourites, is the calcium, and dosage between 500 to 1,000 or so. Do you do that throughout the cycle or just luteal phase?
I do it throughout the cycle.
Okay.
And I keep it more to the 500, especially as they get older, because unfortunately, they talk about higher doses in susceptible women might be increasing the risk of cardiovascular disease. But I think in our 20s and 30s, we're okay with those higher doses.
Yeah, fantastic. So calcium, game changer, I think, for a lot of women with PMDD. And then I think the big thing is just re-emphasising that oestrogen is not the bad guy, and not at all. And it's very, very important for everyone, but especially with PMDD, and we don't want to clear it out. It's more that PMDD is to do with that abnormal reaction to the fluctuations in hormones and that flow-on action to the neurotransmitters.
And I know you've just done a summary, but we really also need to say that because we're working at GABA, how many beautiful herbs have we got that modulate GABA?
Yes.
That are going to be really important for that agitation and irritation.
Yeah.
We've got good documentation that, Melissa, Withania, like a whole, Melissa has had some trialling done on it, but your favourite GABA modulating herbs for that agitation, irritation, and anger kind of symptoms are really important too.
Oh, so many gems. Thank you.
So many gems. Oh, it's been lovely. I look forward to part 2 of this.
Yes, definitely.
Lisa.
Definitely, Sandra. Thank you.
All right, my pleasure. Thank you very much for sharing your knowledge too. It's been great.
Oh, thanks. Thank you everyone for listening today. Don't forget, you can find all our show notes, transcripts and other resources from today's episode on the FX Medicine website. I'm Lisa Costa-Bir, and thanks for joining us. We'll see you next time.
This podcast is intended as healthcare practitioner education only, and it is not a substitute for medical advice, diagnosis, or treatment.
If you enjoyed this episode, please take a moment to give us a rating and review on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to FX Medicine, and share us with your family, friends, and colleagues.